Welcome, and thank you for taking the time to be with us tonight. Tonight's webinar is called Is It Mood or FOH? And we're going to talk about this sometimes confusing process of how to differentiate symptoms of a mood disorder from the temperature-driven symptoms of FOH. For those of you who are new to CMHRC, my name is Elizabeth Errico, and I'm the Executive Director of the Children's Mental Health Resource Center. We are a national nonprofit that provides guidance and resources for early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype, which is known as fear of harm, or FOH. To fulfill this mission, we provide a multitude of services for families as well as for practitioners and educators. These disorders are isolating for children and families and are complicated for providers to treat. So we at CMHRC are here to break down that isolation and provide the information and support that everyone needs to ensure that children and teens can get an accurate diagnosis and a treatment plan that works. You can learn more about our programs and services on our website, cmhrc.org. And if you're interested in any of them, you can make an appointment for a free consultation directly from our website on our services page. You will see these different services listed. When you click on them to read more about them, there will be a button that says schedule a free consultation. Click that and you'll be able to meet with one of us directly to answer your questions. Our services include diagnostic consultation, which we do with families as well as providers to help understand the symptoms and the likely diagnosis that accompanies them. We have school advocacy, where we go in and support families, teachers, and administrators in understanding the mental health aspects of a child's education and how their mental illness presents at school and what interventions the school staff can be prepared to use to help that child succeed. We have community advocacy as well, educating the community about mental health needs. We have our web app, the CMHRC Toolkit, which helps families and practitioners track symptoms, medications, diagnoses, and mood. We even have a weather tracker in there for folks who have FOH. We also have membership programs for families and providers, where we have all sorts of perks like our webinar archive, our clinical seminar archive, educational videos, and more. We also have a program to help families transition from one provider to another. Tonight with me is our clinical coordinator, Jennifer Sevick. Please feel free to put your questions and comments during the presentation into the chat or into the Q&A. She will be answering them as we go and holding some for the end when we'll be able to do a live Q&A. If you'd like a certificate of attendance, by the way, please stick around until the end of the webinar to find out how to make that request. So let's get started. Tonight, our learning objectives revolve around how to understand the differences between mood disorder symptoms and FOH symptoms, and how to understand what stability looks like for each. Since stability for each doesn't necessarily arrive at the same time, it can be hard to identify. So we'll get started with our first objective: what's a mood disorder? But before we can talk about what a mood disorder is, we do have to back up and understand what makes something a disorder in the first place. This can get complicated because nearly every symptom of every disorder that's listed in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, is at one time or another a truly normal human behavior or experience. For example, in oppositional defiant disorder, it includes the symptom often deliberately annoys others. Well, I challenge you to find one set of siblings who don't do that to one another regularly. Narcissistic personality disorder includes the symptom requires excessive admiration. And honestly, it might feel like in our modern world of internet celebrity that it might be hard to throw a stone and not hit somebody desiring excessive admiration. Panic disorder includes the symptoms sweating, trembling or shaking, nausea, and feeling dizzy, all of which can happen when you have the flu and not be symptoms of a panic disorder at all. This is why, in addition to the criteria listed for specific disorders in the DSM, we also have criteria that's included in every single disorder. These universal criteria have to be explicitly excluded or included in order for the behavior, feeling, or experience to be considered psychiatric or psychological in nature. The two things that must always be ruled out before a diagnosis can be made are, can the symptoms be better explained as a reaction to some substance like a medication, alcohol, or illegal drug? And can the symptoms be better explained as part of another medical condition, like in the case of panic disorder, having the flu? The two criteria that must be included in order for experiences to be considered potential psychiatric symptoms are: the symptoms have to cause a marked impairment and be a deviation from an individual's usual level of functioning. This can be measured in performance at school, work, social settings, or in familial relationships. And the symptoms have to cause the individual experiencing them subjective distress. This means that the individual has to have a problem with the symptoms and the impact they have on their life. So, with this in mind, let's look at what the term mood disorder really means. The term describes disruptions in mood states that, generally speaking, don't have an identifiable external cause. So, it's considered normal, for lack of a better word, to feel sadness or disappointment if a promotion you really wanted doesn't come through, or happy and excited if you're looking forward to going on a special vacation. But when mood changes happen without any known environmental or social cause that we can identify, then those changes may be considered a part of dysfunctions in our brain's chemical system for regulating mood. Now, remember, it is still a normal human experience to sometimes feel bad or happy for no apparent reason. We have expressions like, I woke up on the wrong side of the bed, to explain away these unexpected but relatively short-lived mood states. But with mood disorders, clinically significant mood disruptions involve those changes in mood occurring rapidly and unexpectedly and following some sort of daily, weekly, monthly, or annual pattern or cycle. These fluctuations disrupt a person's ability to manage their daily lives, activities, and relationships, and it causes them subjective distress. So let's look at what those symptomatic mood disruptions are. In a mood disorder, fluctuations commonly include feelings and behaviors that we associate with depression and or mania or hypomania. Depressive symptoms include feelings of sadness, irritability, loss of interest in pleasurable activities, and feelings of worthlessness and helplessness. Symptoms of mania include racing thoughts, irritability, distractibility, goal-directed fixations, known as mission mode, and grandiosity. Hypomania looks very similar to mania, but the intensity of the symptoms is reduced. Now, in children, it's really important to note that symptoms of depression, mania, and hypomania can present as chronic irritability, crankiness, a quick temper, as well as rigidity and a refusal to try new things. Mood swings in children can happen quickly, sometimes without any warning or outside stimulus, and can change multiple times throughout a single day. Often, but not always, manic and hypomanic symptoms occur in the late afternoon or in the early evening. Now, mood stability is actually something that's relative, which is why it can be difficult to spot. For example, in someone who's lived with extreme mood disruptions, what they may count as stability may still look and feel a bit unstable to those who have lived with milder symptoms. It's also important to remember that stability isn't the same thing as not having a mental illness. Stability isn't a permanent or fixed state, and stability will always require attention and management. Or, as I like to say, stability is a process, not a destination. And that process is filled with lots of tiny micro corrections that are being made all of the time in order to support stability. That said, patients, parents, providers, they all have some generally expected parameters for what stability will look like relative to instability in an individual patient. And those parameters include fewer mood swings throughout the day, fewer episodes of sadness, general irritability, or feelings of worthlessness, increased participation in enjoyable activities and in being willing to try new things, fewer episodes of racing thoughts, distractibility, and grandiosity, and an increase in flexibility and adaptability. So, when you see reductions in things that are causing subjective distress and an increase in things that promote stability, that's when you're seeing that the mood is beginning to balance. Now, FOH's symptoms are different, and so stability for FOH is going to look different. So now let's look at that. As you know, FOH is an abbreviation for the term fear of harm, which has been used as shorthand for this newly identified phenotype of bipolar disorder, which researchers have changed the name of over the years as new scientific evidence has come to light. Currently, it's called unspecified bipolar thermoregulatory sleep dysregulation disorder. So you can see why we use the easier acronym of FOH. FOH shares symptoms with the mood disorder bipolar disorder, and it shares symptoms such as depressive and manic or hypomanic episodes. But it has its own other specific set of symptoms that are triggered by the biological phenomenon of body temperature dysregulation. This thermodysregulation triggers exaggerated fears, the misfiring of the fight, flight, freeze response, reactive aggression, disrupted sleep, and nightmares. Like its parent condition, bipolar disorder, FOH is a heritable condition that is treatable. But what is temperature dysregulation? Put simply, thermodysregulation is the body's inability to correctly regulate its temperature. This is a physical phenomenon that is independent from the mood disruptions that we talked about before. This temperature disruption is measured in the ratio between proximal and distal body temperatures, which is just a measure of how well the body is shifting heat from its core out to the extremities and the skin so that that heat can be released. Clinical signs of a disturbance in this regulation system may sometimes present in the following ways. Often the person with FOH feels hot and sweaty in normal room temperatures. Parents sometimes refer to their child as a hot box or a radiator. Neutral ambient temperatures don't feel neutral to the person with FOH, and they may feel excessively hot in the evening and cold in the morning. Other telltale signs of temperature dysregulation are bright red ears and cheeks that are often warm or hot to the touch. And another is a refusal to wear weather appropriate clothes. For example, wearing shorts or t-shirts in cold winter temperatures and experiencing little to no discomfort when exposed to the cold. This disruption in body temperature regulation leads to several other symptoms, including fear and anxiety, reactive aggression, and sleep disruptions. Now, I want to talk for a moment before we talk about fear and anxiety, just to be totally clear about something that people sometimes misunderstand. When we talk about exaggerated fears or a misperception of the level of threat in the environment, I want to be really, really clear that we are not talking about one person dismissing the legitimate fears of someone else. In this case, we're talking about children, but in general, because FOH doesn't just affect kids. This has nothing to do with telling someone that their experiences aren't valid. It has nothing to do with gaslighting someone into doubting their perceptions and experiences. This is not about protecting some abuser or perpetrator of violence by denying that that abuse took place. It's not about a PTSD response occurring in someone who's experienced a trauma or a traumatization. None of those things are happening in the identification of misperceptions of threat. Those circumstances would have been identified during a differential diagnosis process, which takes into consideration extensive history. What we're talking about in the case of FOH is a fear that's actually rooted in a biological and physical response to temperature dysregulation, which, truth be told, is not something that most people have been taught to look for. So to learn about it, we all have to sort of stretch a little bit outside of our comfort zone. So how does temperature dysregulation create these intense, exaggerated, larger than life fears and anxieties? Well, it's because the part of the brain that controls temperature regulation is the same part of the brain that controls the activation of the fight, flight, freeze response. And as a result, children with thermoregulatory disturbances experience a triggering of that fight, flight, freeze response when it's not needed, causing them to feel unnecessary, intense anxiety and fear. The child is on constant alert, looking for threats and dangers, causing separation anxiety, fears of things like germs, intruders, or the dark, and they're pushed to really debilitating degrees. They create elaborate rituals at bedtime, mealtime, or bath time in order to help them feel safe. When they're functioning in a near constant state of fight or flight, it also results in distorted reactions to normal stimuli. They experience threats that don't exist, either by misperceiving something neutral as threatening or by feeling excessively defensive. This usually comes from feeling embarrassed, misunderstood, unheard, dismissed, or rejected. Now, as for aggression, all children can be aggressive at times, and it can be difficult to differentiate clinically significant aggression from either normal childhood behaviors or from other diagnoses. It's developmentally normal for young children to have tantrums. However, in a child triggered by thermodysregulation, their tantrums continue for many years past what's considered developmentally normal. The tantrums can also last for several hours at a stretch and are often accompanied by physical and verbal aggression, such as screaming, throwing things, slamming doors, putting holes in walls, kicking, hitting, biting, and scratching. These behaviors escalate with the child's age to include cursing and verbal threats. Parents know when their child's tantrums are unusual and deviate from the developmentally normal outbursts that occur in early childhood. Aggression can also be shown in other ways, such as defiant and oppositional behavior, refusals to follow simple instructions, refusal to complete expected tasks, and to do basic chores such as teeth brushing, showering, homework, and getting dressed. Requests can be met with verbal abuse, and it can quickly escalate into tantrums, leaving parents, siblings, caregivers feeling as though they're walking on eggshells all of the time. Now, the sleep-wake disturbances that are caused by temperature dysregulation are broken down into three separate categories of disruptions, which include parasomnias, nightmares and night terrors, and circadian rhythm changes. Parasomnia is a term that's used in the DSM and by sleep specialists to describe disruptions that demonstrate that there are problems with the brain's execution of the natural sleep cycles. These include things like sleepwalking, sleep talking, night sweats, bedwetting, and teeth grinding. The second category of sleep disturbances are nightmares and night terrors. Now, everyone has the occasional bad dream, but these nightmares and night terrors are frequent, as in they're happening 3 to 5 nights a week, and the dreams are recurrent and can happen sometimes multiple times a night. The dreams are themed with pursuit or abandonment. They are violent and often gory imagery involving scenarios where they or someone they love is being hurt, maimed, or killed. And I want to stress that these nightmares and night terrors are not based around things that the child is experiencing in daily life. They don't live in an abusive environment. They're not watching scary, gory movies. These dreams are coming out of that temperature dysregulated fight, flight, or freeze response where they are living out that terror in their dreams. The next day, when they are awake, though, those images linger long after they awaken and plague them throughout the day as recurrent, repetitive, intrusive thoughts, which is a post-traumatic response to the imagery from the nightmares. Alterations in circadian rhythms are alterations in our body's natural sleep and wake rhythms that help us tell night from day and day from night. The disruptions in these rhythms include difficulty falling asleep, which can be seen pretty easily in kids when they have a very difficult time winding down in the evenings and preparing for sleep. What's happening is they're actually experiencing rising energy levels, anticipatory dread about being unable to fall asleep, and anticipatory fears about the nightmares that they frequently have. Circadian rhythm changes also include difficulty staying asleep, which involves frequent middle of the night awakenings, trips to the bathroom, and restlessness, which is easy to observe from bed sheets, pillows, pajamas, all being in wild disarray, kicked off on the floor, etc. Sleep-wake disturbances can also include difficulty waking when the person doesn't appear to have the energy to move in the morning when awakened, and they frequently fall back into a deep sleep and can't rouse themselves. Kids will sometimes say that their legs don't work. Parents are inclined to see this as just a stalling tactic, that they don't want to get out of bed, don't want to get dressed, don't want to get ready for school. But that is absolutely not the case. When kids can't wake up in the morning and they have FOH, it's because they're experiencing a circadian rhythm disruption that is making it impossible for them to wake up long enough to get out of bed. And this is being caused by the fact that their body temperature is staying low when it's supposed to be rising. Finally, the most extreme version of circadian rhythm changes is when the brain and body's clocks no longer have the ability to tell day from night, and there's a complete reversal of day and night, with extended sleep hours only occurring during the day when it's light outside. Now, just as with mood stability, FOH stability is also somewhat relative. And what you're looking for as a first sign of stability is to see some basic decreases in symptom frequency, intensity, and duration. More specifically, in that vein, we're looking for signs of less fear, more confidence in social interactions, reduced oppositional behaviors, reduced aggression, and improved sleep quality and duration. Now, regardless of what's causing symptoms, it is extremely important to be able to recognize behaviors as symptoms. Whether we're talking about a mood disorder, bipolar disorder, or FOH, it is not unusual for the symptoms to be misinterpreted by others as intentional behaviors, which they're not. Behaviors are just the most easily observable, but behaviors, feelings, and thoughts are all impacted by symptoms, and it is inaccurate to attribute intention to them under these circumstances. Here's an easy way to think of it. We don't blame a child for having a nightmare. We recognize that when they're asleep, their brain chemistry produces nightmares against their will. And the experience of a nightmare is distressing, if not traumatizing. We have to have the same perspective for a child who kicks a hole in the wall during an extreme fear episode involving a misplaced fight or flight response. This symptom presents as a behavior, but it's still the result of their brain chemistry producing a symptom against their will. Calling it a behavior just because they were awake when it happens doesn't make it any more intentional than having a nightmare. It also doesn't make it any less distressing or traumatic for them, especially when they're being blamed for symptoms over which they have no control. So now that we understand what mood disruptions are, what they look like, and what FOH symptoms are and how they present, we come to the most common question parents and teachers ask, which is, how do I know which is which in the moment? And how do I know what to do about it? So it can be hard to tell the difference in the moment between aggression caused by irritability versus aggression caused by temperature disruptions. And in the moment, you're not going to go back and dig into the data that you've been collecting on symptom frequency and triggers, et cetera, et cetera. In the moment, you're not going to be able to dig into that data. Our CMHRC toolkit, by the way, though, helps you collect all of this data in one place with easy to read graphs and severity scores, and it's free with membership, but you don't have to be a member to access it. You can go to our website and check out toolkit under the services tab of our main menu and find it. But when you keep track of that stuff, later on you can go back and you can look at the data and you can see what was happening. And keeping data like that is extremely helpful. And it's something we help families, providers, and teachers figure out how to go through and interpret. And we do that with our consultation services. But again, in the moment, you're not going to be able to stop the crisis and go refer to your data. You're going to do that afterwards. But in the moment, there's actually a really easy answer. That simple answer is when you're in doubt of whether or not the symptoms you're seeing are caused by mood disruptions or temperature dysregulation, try a cooling strategy. If it works, then you know the symptoms were temperature driven. If the cooling strategies don't work, then you have done absolutely no harm and you can try a mood-based intervention instead. For some of you who may be new to learning about the FOH diagnosis, you may not know what I'm talking about when I say you can use cooling strategies. CMHRC members can access our webinar archive and watch the recording of our July webinar called Cooling Strategies and Cooling Plans to learn more. But we're going to quickly touch on that process now. We use the term cooling strategies because when dealing with temperature dysregulation, we're usually trying to release built up body heat that hasn't been properly dissipated. And so we tend to think of it in terms of cooling down. It's really just shorthand, though, for body temperature stabilization. The overall goal of cooling strategies is not to make the person cold. This would actually be counterproductive because it would trigger the body to warm itself up again, which actually just restarts the cycle of overheating. The goal is just to help the body release that built up heat and return itself to a state of equilibrium. To do this, we have to be able to identify when cooling strategies are needed. It could be that you're seeing dysregulated mood, dysregulated behaviors, or disrupted sleep, and you're trying to figure out what's causing it. A clue that you're dealing with temperature dysregulation and not general mood symptoms is you can observe the physical symptoms of it through the red ears that are warm or hot to the touch, hot flushed cheeks, and excessive sweating. Or you're seeing behaviors like aggression, extreme defensiveness and reactivity, oversensitivity, and larger than life fears. To deal with temperature disruptions and the behavioral symptoms that go along with it, we use what we call preventative and corrective cooling. For starters, in order to prevent symptom outbreaks that are driven by temperature dysregulation, we use preventative cooling strategies which work to prevent overheating from happening in the first place. And while they're basically all the same, specific techniques While they're all basically the same techniques as are used in the corrective strategies, by using them proactively throughout the day and on a schedule, this prevention is able to stop the temperature disruptions before they start. But when a symptom outbreak has already begun, you may not be sure what's causing it, temperature or mood. This is when we use the corrective cooling approach as our first line of defense. It's going to help work to regulate the body's temperature, de-escalate behavioral symptoms, and bring that overheating person back to a place of body temperature stabilization. If the corrective strategies succeed, then you know you've been dealing with temperature-triggered FOH symptoms. If corrective cooling strategies don't succeed, then you know you've been dealing with symptoms of mood disruption. In that case, you'll then use interventions designed to support mood disruptions, such as the psychotherapy, medication adjustments, social supports, improvements to the sleep routine, and diet and exercise adjustments, which may be more effective tools to address the outbreak. Next month, we're actually doing a webinar entirely about diet interventions to support mood stability. We're going to be meeting with a mother and son who've successfully used ketogenic therapies to stabilize mood disruptions. Ketogenic therapies are more commonly known as the ketogenic diet or keto diet. We're going to be discussing their success with ketogenic therapy in our webinar next month, and it's going to be the first of a two-parter combined with our clinical seminar next month, when we'll be meeting with the medical director of Metabolic Mind, which is a nonprofit institute that researches metabolic therapies to treat mood disorders. So that I highly recommend you attend, or if you're watching this recording after the fact, that you find that in our webinar and clinical seminar archives as well, so that you can watch it, because it's something that has tremendous promise to sort of reshape how we treat mood disorders. So while our previous webinars go into a lot of detail on the various cooling interventions that can be used, the simplest explanation is that the cooling interventions fall into 4 primary categories: submersion, eating and drinking, adding coolness, and removing heat. Briefly, each of these can be summed up. Submersion involves making the core of the body, the hands, wrists, feet, ankles, and sometimes the head, submerging them in tepid water, which is cool enough to pull heat out of the body and warm enough not to make the person feel cold. These are various methods for getting these cooling benefits of submersion. We recommend 78 to 82 degrees Fahrenheit, which is roughly the temperature of your typical indoor pool. Eating and drinking cold things is simple. By putting icy cold food and drinks into the body, literally cools the core of the body from the inside out, allowing the coolness to radiate out from the stomach. You can be creative with these treats, from frozen fruit to sports drinks to homemade popsicles and smoothies. There's nothing really but your personal taste and imagination limiting your options. Adding coolness to the body and removing heat are the flip sides of the same coin. With the first, we use cooling cloths, ice packs, frozen gel packs to pull heat out of the body, placing them on the neck, the chest, the hands, the wrists. Removing heat is about air circulation, exposing the skin to air to pull the heat away from the skin. This involves using fans, exposing the skin, reducing clothing, using athletic clothes that cool by pulling moisture and sweat away from the skin, and having ceiling and floor fans going pretty much all the time. Many parents begin their journey learning about FOH despairing that it's too difficult to tell what's what or to know how to intervene effectively. But once you get the hang of it, and you will, it will become second nature to just use the cooling strategies as the first line of defense against symptom outbreaks and challenging behaviors. Start with keeping and reviewing regular logs of mood and temperature fluctuations. You can use the CMHRC toolkit to do that. Reach out to admin@cmhrc.org to get started with the toolkit. You can maintain a schedule of consistent preventative cooling strategies, like incorporating frozen foods into daily food plans, taking regular baths or showers in the evening before bed, and keeping ceiling fans running in the house. You want to use those same strategies and others when symptoms break out to see if a temperature adjustment is needed. And you're going to want to use psychotherapy, medication, and other lifestyle tools to address the mood-related symptoms. With this plan in place, life with a mood disorder, bipolar disorder, or FOH isn't going to be easy, but you will feel more confident and you will be able to manage the unexpected that life and this disorder send your way. You can find some of the products our community of families have recommended for cooling purposes on our website, cmhrc.org. You can have also just the peace of mind of knowing that these are actual items that families have actually used, and they have reported that they have actually helped manage their temperature dysregulation and have in turn helped their mental health. You can use the link here, which is kind of long. So just go to our website, cmhrc.org, and select recommended products from the free resources menu tab. Also, I'd like to make sure that people know that we do not receive any commission or fees for sharing these recommendations from our community of families. Now, this slide has information on the works used in the development of this presentation. And if you would like a certificate of attendance or completion for this webinar, please email programs@cmhrc.org, and make sure in your email you let us know if you are a mental health professional or a family member, because we have different certificates depending upon that factor. So now we can dive into a Q&A for a few minutes. Jen, are there questions coming in that we can answer or that you've held on for discussion?